We're going to talk about chapter 58, which is amniotic fluid and the fetal membranes. So let's do it. So, the role of the amniotic fluid, which is all the black that we see around the baby, allows the fetus to move freely within the amniotic cavity. That's a huge thing. It maintains the intrauterine temperature, it protects the developing fetus from injury. Abnormalities of the fluid may interfere with the normal fetal development, cause structural abnormalities because the baby can't grow correctly, or be an indirect sign of underlying anomalies, such as a neural tube defect or a GI disorder. The amniotic cavity forms early in the fetal life and is filled with amniotic fluid. The fluid completely surrounds, protects the embryo and the fetus. The amniotic fluid is produced by the umbilical cord, membranes, lungs, skin, and kidneys. And the amount of amniotic fluid reflects balance of the production and the removal. As the fetus and the placenta mature, the amniotic fluid production and consumption change. And the changes include movement of the fluid across the chorion frondosum and the fetal skin. The fetal urine output and the fetal swallowing is a huge thing later on in the second trimester, and GI absorption. The portion of the chorion that develops into the fetal portion of the placenta is the chorion frondosum, and it's a site where water is exchanged freely between the fetal blood and the amniotic fluid. The fetal skin is actually permeable to water and solutes and allows direct exchange between the fetus and the amniotic fluid until keratinization that occurs 24 to 26 weeks. The fetal production of the urine and the ability to swallow begins between 8 and 11 weeks. And the amount of urine produced is most significant at approximately 18 to 20 weeks gestation. So, anytime that I can see in the first trimester a good stomach and a good bladder, like around 12 weeks, I feel really good that the baby is swallowing correctly and the kidneys are producing the urine from the amniotic fluid. And those are two really great signs. The fetal urination into the sac accounts for nearly total volume of the amniotic fluid in the second half of pregnancy. So, if we're thinking back, which we'll talk about in the urogenital chapter, but we know that the amniotic fluid is crucial to the viability of the baby. So, if the kidneys aren't functioning, or there aren't kidneys, or there's something blocking the kidneys or the bladder, and the amniotic fluid cannot be produced, then the baby is not going to be able to survive, which makes the kidneys a very, very, very important thing. The quantity of the fluid directly related to kidney function. In a fetus with malformed kidneys or renal agencies results in little and no amniotic fluid. Fetal swallows amniotic fluid, which absorbs by the digestive tract. So let's talk about this because might be an essay question for you guys on your test is um, what does the amniotic fluid do? So it acts as a cushion to protect the fetus, allows embryonic and fetal movements, prevents adherence of amnion to the embryo, allows symmetric growth, maintains constant temperature, and acts as a reservoir to fetal metabolites before excretion by the maternal system. Now, another thing that you need to know is the amount of the amniotic fluid is regulated by production of the fluid, removal of the fluid by swallowing, fluid exchange within the lungs, in the membranes and cord. So the reason, well, besides other reasons, but one of the big, big reasons is normal lung development depends on the exchange of the amniotic fluid within the lungs. The baby needs to breathe in that fluid to develop the lungs correctly. If there's no fluid or very little fluid, the baby's lungs can't develop correctly. And when the baby is delivered, it cannot breathe on its own. So the inadequate lung development may occur when amniotic fluid is severely low, and this places the fetus at a high risk for developing small hypoplastic lungs, and the babies are not viable at that time with those. The amniotic fluid volume regulation. So the amniotic fluid volume increases rapidly during the first trimester. The fetus swallows the fluid, reabsorbed into the GI tract, and recirculates through the kidneys. And then with the kidneys, then produce urine, um, then the baby urinates, and it happens all again. The increased amniotic fluid production in the first trimester, and by 20 weeks gestation, amniotic fluid volume is increasing by 10 milliliters a day. And the fluid produced by the fetal urination slightly exceeds the amount removed by swallowing, so it increases the fluid. This is all the black is the fluid. Here's another. Sometimes they can get, especially later on, like 37, when the babies are at term, you can see these little spots, and that's the vernix. It's part of the skin, and that is kind of shedding off there. So sometimes it can look like that. That's normal. Now, when we're doing an anatomy scan, like a 20-week scan, I don't necessarily want you guys don't have to take a fluid measurement at the time because the uterus is still kind of small to separate it into 4 quadrants. So the subjective assessment is performed as a sonographer initially scans through the entire uterus to determine a visual eyeball. So what I usually do when I'm doing a complete scan at 20 weeks, making sure everything looks good, I just assess the fluid subjectively. Does the fluid look good to me? If I feel like it looks like the baby has too much or too little, then I'll take a measurement. But around 20 weeks gestation, it's more of like an eyeball. I feel like when the placenta is in a posterior placement, it looks like there's more fluid, which can kind of trip you up. So this is the subjective assessment of the fluid. I would say this looks like a good amount of fluid, and just keep it at that normal amount. Here is another baby with a placenta that is anterior. This still looks like a normal amount of fluid around the baby. Look how cute that little profile is. Subjective assessment looks good, normal amount. Now, this is a difficult one to see, but I can see that I'm like, oh, that looks like that baby is pretty far down there from the placenta. There's quite a bit of fluid. And this thing, I would probably go ahead and take a fluid measurement. So I have had students in the past that have text me or messaged me after they've even graduated and like, when do you start doing an amniotic fluid index? And it's different at different places, but the amniotic fluid index is basically when we are dividing the uterine cavity into 4 equal quadrants, and then you take a measurement at each quadrant. And I like to do this at 24 weeks gestation. 24 weeks gestation is when I always start doing an amniotic fluid index. So it went from subjective assessment, where you're kind of looking at it yourself and being like, okay, it's normal, it's abnormal, to actually doing a measurement. So 24 weeks gestation is what I always tell my students, that's when you need to start doing an AFI, an amniotic fluid index. We will work on amniotic fluid index pretty fast. It'll be one of the first things that you guys do. So the largest vertical pocket of the amniotic fluid, excluding fetal limbs or umbilical cord loops, is measured. So this is what an amniotic fluid index looks like. So you cut the quadrant, or you do 4 quadrants. Here, I have another image here. This is mom's belly. So 1, 2, 3, 4 here. That's how you do it. And then you measure the largest pocket in each place. Then the machine calculates an amniotic fluid index for you. The normal this is different than your book, and I changed this, and I want you to know because it's just black and white. There's no like, well, maybe it's normal, maybe it's not. Nope, this is what I like you to know. Normal amniotic fluid correlates AFI of 5 to 24. So if you have a fluid index, although it's low at 5 centimeters, it's still considered normal. If you have one at 23.99 or 24 centimeters, it's still considered normal. If it's above that, then it's abnormal. Now you can have values from 5 to 10 centimeters indicate lower fluid, and values of 20 to 24 indicate increased fluid. Now, if I had a mom that had a fluid index of like 5.2 at 30 weeks gestation, then I would note it. I would still say fluid appears it's a normal amount of fluid, but it appears low, just because it's on that brink of at 30 weeks gestation, they should have 18 to 19 to 20 centimeters of fluid. They shouldn't have 5. Um, but it is more black and white if 5 to 24 is considered normal, although it's lower fluid and it would be something that you would want to mention. So oligohydramnios correlates with amniotic fluid that is less than 5 centimeters. Like this is one of your most important slides ever, guys. So just not even for my test, but just in general doing OB. So I hope that you will really take to heart this slide. Oligohydramnios correlates with amniotic fluid index of less than 5 centimeters, with the largest vertical pocket measuring 2 centimeters or less. Now, you remember when we talked about a biophysical profile? And in your biophysical profile, you have 4 things that you're looking at: fetal breathing, fetal movement, fetal tone, and amniotic fluid index. Now, if you or the amniotic fluid. Now, if you remember, how a baby scores 2 points is if you can get a vertical pocket measuring 2 centimeters or greater. If it's less, it's considered oligohydramnios. Does that make sense? I hope. Polyhydramnios correlates with an amniotic fluid index of greater than 24 centimeters. So the largest pocket of 8 centimeters or more would be polyhydramnios. So we do a single pocket assessment sometimes earlier on if you feel like at 20 weeks gestation and you're doing a complete scan and it just looks like there's quite a bit of fluid. Probably would just do a maximum vertical pocket. So what that means, if you find a pocket of fluid where there's no limbs, there's no cord, and you measure from top to bottom, and if it's greater than 8 centimeters, that would mean that there's more than fluid than there should be. So this is a huge single pocket assessment. So this mom has like severe polyhydramnios because 1 quadrant of fluid has 18 centimeters. The depth of the pocket is measured at right angles to the uterine contour and is placed in 3 categories. So this is what I want you to know. Less than 2 centimeters is oligo. 2 to 8 is normal amniotic fluid. Greater than 8 is polyhydramnios. The other time we use single pocket assessments is always on twins, which we'll talk about a little bit later. Right now, we'll talk about it. In twin pregnancy, it's important to assess each sac independently when performing amniotic fluid determinations. Twin pregnancies have a slightly lower median AFI value than singleton pregnancies. So it's just really difficult if you would think that you would have to separate. It's just impossible to separate the 2 sacs into 4 quadrants. So what we end up doing is doing a max twin vertical pocket on each sac of each twin or each baby. Two diameter pocket where you would do like an anterior posterior and length measurement appears to be a better predictor. But we most of the time just do a largest vertical pocket, which is an LVP. And that's what it would look like. It would just like you would find the most fluid in baby A sac, and then you would measure just a straight vertical pocket. So this baby A has 8.72. So this baby would have polyhydramnios. Baby B's is 10.5. So this baby would also have polyhydramnios. So they both have increased fluid. Now, severe polyhydramnios is associated with increased perinatal mortality, morbidity, and maternal complications. The patient will present with clinical findings of the uterus greater than dates, sonography ordered to rule out multiple gestation, molar pregnancy, or fetal size greater than dates. But sometimes what ends up happening when we do an ultrasound is what is making the mom's tummy big is the fluid. So the amniotic fluid compartment is in dynamic equilibrium with the fetal and maternal components. In polyhydramnios, the equilibrium shifts, so the net transfer of water is into the amniotic space. For some reason, the baby is not absorbing as much as it should or swallowing as much as it should. Increased amniotic fluid produces uterine stretching and enlargement that may lead to preterm labor, various other maternal symptoms. Acute onset of hydramnios may be painful because the tummy is so tight, compress other organs or vascular structures, cause hydronephrosis, or produce short of breath, mom to be short of breath because of the increased fluid. Polyhydramnios is often associated with central nervous system disorders and GI problems. The central nervous system disorders cause depressed swallowing. GI abnormalities result in ineffective swallowing that is often caused by a blockage of the esophagus, stomach, duodenum, and small bladder. So, if the baby has something going on with the nervous system or GI, that tends to be a reason why they would have polyhydramnios. Fetal hydrops, skeletal anomalies, some renal disorders may be associated with hydramnios. I tend to see maternal conditions. Diabetes definitely seems to be more associated with that. Obesity, RH incompatibility, anemia, and congestive cardiac failure. So what will you see? Well, you'll see a baby floating around in a lot of fluid. Um, we tend to lighten it up a little bit and say these babies are going to be great swimmers. Accentuated fetal anatomy, increased amniotic fluid improves image resolution, and AFI greater than 24. Now, I feel like these babies do the best 3D ultrasound pictures because they have so much fluid, and you can just see so well because of the increased amniotic fluid producing better image resolution. And I just love to take pictures of these babies that have more fluid. They're gorgeous. Whoa, look at this one, guys. 13 centimeters. So this mom has AFI of 32 centimeters. So that's definitely increased. Okay, so on the other side, oligohydramnios is the overall reduction in amount of amniotic fluid resulting in fetal crowding and decreased fetal movement. I feel like this is a little bit more scary than polyhydramnios for me. The development of oligohydramnios may be caused by congenital anomalies, IUGR, post-term pregnancies, rupture of membranes, or it just could be. Second trimester oligohydramnios often has poor prognosis. And why do you think that is? Because those lungs can't develop correctly, right? The maternal conditions associated with oligo are hypertension, preeclampsia, chronic cardiac and renal disease, connective tissue disorders, and patients receiving indomethacin. Fetal hypoxemia may produce growth restriction and oligohydramnios. So if they're not getting enough oxygen, fourfold increased risk of growth delay when oligohydramnios is present, so the baby can't grow as correctly. And a Doppler evaluation of growth restricted fetus shows abnormal umbilical flow. Placental insufficiency may cause IUGR and associated with oligohydramnios, and it produces distribution of fetal blood flow away from the kidneys toward the brain to counteract the hypoxia. Results in decreased urine output. So babies that have IUGR, you can think most of the time, or a lot of the times, they will have lower fluid, sometimes oligo. Post-term pregnancy is defined as gestational age of 42 weeks, and it's a very common complication when the babies won't come out. And this is just, I most of the time just think because the placenta is just done, it's tired. Other reasons why would be like some medications, fluid loss, intravascular fluid depletion, prior procedures such as a CVS. Medications associated with oligohydramnios are non-steroidal anti-inflammatory drugs, nitrous oxide, enzyme inhibitors, calcium channel blockers. You don't really need to know these. So you do need to know that some of the non-anomalous white conditions would be IUGR, premature rupture of membranes, post-date pregnancies, and chorionic villus sampling. Those would be things that occur with the baby that are not an anomaly that could cause oligo. Fetal anomalies that can cause it are infantile polycystic kidney disease. You need to know that. Renal agenesis if they just don't have kidneys. Posterior urethral valve syndrome, which is a blockage in the urethra. Dysplastic kidneys. Kidneys aren't functioning normal, and a chromosomal abnormality. So with oligohydramnios, instead of seeing a lot of black fluid, you're just going to see the baby and the placenta. And there's just not much room for the baby to move. These babies don't image very well because there's no fluid. Oh, this is an image of the amnion cavity and the chorionic cavity. So eventually the amnion keeps spreading and spreading and spreading and will connect with the chorion cavity. And then they will merge together. This is the amnion that's not attached to the chorion yet with fetal membranes. Okay, so have you guys heard of ruptured fetal membranes? Probably not that, but you have heard of water breaking, right? Like the mom's water breaks. So basically the membranes normally rupture after onset of labor. So premature rupture of membranes or preterm premature rupture of membranes or spontaneous rupture of membranes, most of the time we just say PROM, describes condition in which the membranes rupture or the water breaks abnormally, resulting in loss of amniotic fluid or oligohydramnios. So you want the water to break when the mom is 40 weeks pregnant and is going into labor, but you don't want the water to break early. Clinical findings, the patients suspected to have ruptured membranes are present clinically with a sudden gush or leaking of fluid. And what they can do is they have this nitrazine paper and Fern test that they use as screening tests to determine if the presence of amniotic fluid in vaginal secretions. So they can test it to see if that really is amniotic fluid that's coming out of the vaginal canal. And patients checked with cervical dilatation and for leaking of fluid with coughing or fundal pressure. The prognosis of the fetus is affected by abnormal ruptured membranes, depends on the fetal gestational age, fetal status, ability to control the uterine contractions. Abnormal rupture membranes is associated with preterm delivery, fetal neonatal death, respiratory distress, prolapsed umbilical cord, chorioamniotitis, and placental abruption. The role of sonography is to document integrity of the placenta, fetal size, amniotic fluid, fetal well-being, and to perform fetal Doppler studies. Common for patients to be evaluated every day to assess for fetal well-being and fluid volumes. So if they have ruptured membranes early, but they don't want to deliver the baby yet, they'll keep them in the hospital, and they do ultrasounds to monitor the baby. You evaluate the integrity of the placenta, fetal growth, and biophysical profile. But a placental abruption, which is more of a medical emergency, is associated with ruptured membranes. So when a mom ruptures membranes, there's not going to be much fluid left. So it's going to look like this. There's no black, there's no fluid. It depends on where the mom is in gestation if the baby's going to be okay. Now, if it's in the third trimester, like 34 weeks, the baby has had time to develop the lungs. And so that would be, those babies have a better chance of being viable. Now, where it gets Scary is when this happens in the early second trimester when the baby hasn't had time to really develop the lungs yet. So let's talk a little bit about amniotic band syndrome, and it's associated with abnormality in fetal membranes as a common non-recurrent cause of various fetal malformations involving limbs, craniofacial region, and trunks. It's basically where the amnion, which is sticky, gets stuck to the baby. So the most widely accepted theory why this happens is the rupture of amnion during early pregnancy development leads to subsequent entanglement of various embryonic or fetal parts. The amnion is contiguous with the fetal skin at the umbilicus and is thought to protect the fetus from contact with the chorion. But when the disruption of the amnion occurs, fetus may adhere to and fuse the chorion, and maldevelopment can happen. Various congenital malformation syndromes thought to be caused by compression of fetus by amniotic bands, which can result in abnormalities or fetal death. Now, these are very not common at all, but I have seen them a couple times. It's a milder form of limb body wall complex, which we'll talk about. So basically, what happens is when the baby is developing, part of the like a band of amnion gets stuck to the baby or entangles the baby. Well, the baby can't develop correctly when this happens, so it and circulation doesn't occur correctly, so it could amputate fetal parts. If there's an amniotic band that is connected to the face, that could cause like a facial cleft. If it's connected to the brain, it could cause an encephalocele, which is a brain herniation. Um, could cause amputation of extremities or club foot deformities. Here is a little amniotic band. Here's another one. Looks like it might be stuck to the hand. So if you were to see like a little band like this, what you would do is you would take a cine clip of it and see if it's connected to a part of the baby. If the baby moves freely and it doesn't seem to be connected, it's what we call a sneaky eye, which we'll talk about in just a second, which is more of a uterine band than an amnion band that doesn't cause issues as much. But if it is connected to the baby and you don't see much movement, that would be a cause for concern. Here's another amniotic band. There's an amniotic band that's attached to the hand. So there is a limitation of movement there. Here is one that would be connected to the face. Following the band closely with real-time scanning, the sonographer can observe where the band is attached to the uterine wall and what, if any, constriction is placed on the fetus. Here is one, you can see the indent here of the skin. There's an amniotic band that is connected to the arm. So amniotic sheets or shelves or folds identified as echogenic non-floating bands crossing through the amniotic cavity. These are thicker bands than amniotic band syndrome and don't cause fetal malformation. They're uterine sneaky eye, which is they are more like from previous trauma to the endometrium, like if they've had a previous delivery or C-section or D&C or something. Patients with a history of these would be a reason why they would have uterine scars. I'll show you. Patients who are diagnosed with these and infertility are also often diagnosed with Asherman syndrome, which is basically where there's too many. I don't know how I would want to say it. There's too many bands or there's too much scarring in the endometrium that is not allowing the embryo to adhere to the endometrial cavity and grow, if that makes sense. So Asano findings may show fine echo-dense line in the uterine cavity separated from the uterine wall by echolucent space, and the membrane may be either completely surrounded by the fetus or be freely mobile in the amniotic cavity. Can appear anywhere in the uterine or cervical cavity and are seen extending from one side of the uterus to the other, oblique across uterus as multiple echogenic lines. So here we are. This is just a thicker separation here. It's you can see uterine syncytiae and it won't cause any issues. Last thing I want to talk about is hydrops. Now, hydrops is a disparity between the amounts of serous fluid being produced and absorbed. So the baby accumulates fluid. The fetus will have fluid within at least two of these places. So pleural effusion, which is fluid within the lungs, ascites more in the belly, cardiac effusion around the heart, skin edema or anasarca, which is basically fluid around the whole baby, severe fluid. Other fetal findings identified enlarged umbilical cord, polyhydramnios, placentas, enlarged liver and spleen. A lot of the times, if a baby gets hydrops, it's highly associated with mortality rate. Hydrops is identified on ultrasound by presence of abnormal collections of fluid. The ascites can be seen as anechoic fluid surrounding an abdomen, pelvic organs, and umbilical cord. Just basically like what you would see ascites in a adult patient. Don't mistake the normal hypoechoic abdominal musculature for ascites. So all this black, this is the little liver. That's the little stomach, and all this black around the baby. This is a transverse view of the abdomen. This is ascites. Pleural effusions can be seen as anechoic fluid filling in thoracic cavity. So here's the heart, and then the around it is fluid. Skin edema can be seen as increased skin thickening around the skull neck, and greater than 5 to 6 millimeters is considered. So what that means is like thickened around the wall here. This is really thickened skin around the head. Pericardial effusion is seen as excess anechoic fluid in the pericardial cavity. If it's greater than 2 millimeters, it's called a pericardial effusion. So this is a little 4-chamber heart here, and this is fluid around there. Placenta edema can be seen as a thickened placenta greater than 4 to 4.5 centimeters. So why do babies get hydrops? Why do they get an accumulation of fluid? Well, there's two different things. One of them is immune hydrops, and this doesn't happen very often anymore because of medical advances, but it's associated with the alloimmune hemolytic disease, or isoimmunization. Now, I know if you've had a baby before and you are Rh negative, you might have to get a RhoGAM shot. So maternal blood sampling or history of previously affected fetus extremely important in pregnancy management. So I believe that when you are Rh negative first baby, or second baby, they give you a RhoGAM shot to make sure that this doesn't happen. And so this is how. So you have a Rh positive father, Rh negative mother, the Rh negative mother with a Rh positive baby. So the Rh positive baby's blood cells enter mother's bloodstream at delivery. The invading Rh positive blood cells cause the production of Rh antibodies. So now the mom has antibodies to fight if this happens again. The Rh antibodies remain in mother's bloodstream, but then she gets pregnant with a Rh positive baby again, and the Rh antibodies attack the Rh positive baby's blood cells, causing Rh disease, which causes immune hydrops, causes the baby to potentially die, and that's what immune hydrops is. Now they give you a RhoGAM shot to make sure that this doesn't happen. So we don't see it in developing countries very much at all, or if a patient has prenatal care. Non-immune hydrops drops is what we see more often. And it's the presence of abnormal accumulations of fluid in the fetal body or skin for different causes. We'll talk about the causes. Could be sporadic, but most of the time there's something else going on. Cardiac insufficiency is one of the most common causes. And I feel like if a baby has a cardiac tumor or has tachycardia or supraventricular tachycardia, where the heart is just beating like crazy, like 220 beats per minute, it could cause hydrops, fluid accumulation. Look at this heart rate going 246 beats per minute. If the heart continues to do that, it's not good. Fetal anomalies associated with decreased venous return to heart, structural lymphatic obstructions, and hyperproteinuria or other causes. Sono findings, all abnormal fluid collections should be documented and measured. And then fetus should be evaluated for anomalies. There could be fetal tumors, cardiac anomalies, a cystic adenomatoid malformation of the lung, or a chorioangioma of the placenta. Due to their relationship with this, sono findings associated with characteristics of the following should be documented: trisomy 21, 45X, or fetal infections, torch. Okay, so where I've seen non-immune hydrops the most is in a baby that has Turner syndrome, which is 45X. Those babies that have that or that chromosomal abnormality tend to have hydrops. The other thing I've seen is if a baby has an infection such as toxoplasmosis, rubella, cytomegalovirus, any kind of thing that can occur to them in early pregnancy where there's an infection that the baby is exposed to can cause non-immune hydrops. Those are the times that I have seen it the most. Massive skin edema in a baby with fetus with trisomy 21. Here's another massive skin edema here. All right, that's it for today. Have a good day.